Welcome back. It is the second part of lesson number 9. In this part of the lesson, we address problems concerning food, nutrition, and hydration. Part 2 of this lesson is about nutrition in advanced Parkinson's disease and covers the following subjects: comprehending the social importance of food, nutrition and hydration in advanced stage of Parkinson's disease, using pumps and feeding tubes, ethical and social implication of feeding tubes, for example PEG tubes, nursing care and prevention, nutrition at the end of life, and the importance of involving spiritual counselors. In this learning unit, different aspects of nutrition for Parkinson's patients will be discussed. The meaning of food is much more than satiation. Here we will briefly describe individual aspects of the social meaning of food. Understanding the social aspects of eating is an important basis for dealing with problems that may arise during the course of the illness. Especially in the advanced stages of the disease, patients and their relatives are often confronted with swallowing problems. The medical background of the symptom will be explained. An essential point will be the discussion whether the installation of a gastric tube is reasonable and what this means for a patient, and to discuss the alternatives. The proper care around stomach tubes is explained and speech therapeutic recommendations for eating are given. We start with the topic comprehending the social importance of food. Eating is much more than the mere intake of food. If one starts at the beginning of life, the infant is fed by the parents. On the one hand, the act of feeding is connected with a feeling of care. On the other hand, the act of feeding is connected with a feeling of security. Offering food to adults can also be linked to different feelings or intentions. Food offering can be used to show affection to loved ones, to show hospitality to strangers, or to adhere to or express religious beliefs. Here are some aspects that make it even clearer that food intake or eating has complex social meanings as published by Hamburg et al. Infants learn from an early age to associate food with soothing and social interaction. Food items do not merely represent a means to satiety, but can also signify comfort or reward. For example, opening a bottle of champagne often signals a celebration of success, and eating lots of ice cream often signifies consolation after a disappointment. Eating is an inherently social behavior. A meal shared with others is held in higher esteem and regarded as more of a proper meal than food consumed by oneself. An interesting observation is that meal size decreased as social intimacy decreased, with meals being smallest when consumed alone, and without limitation to religions and cultures. One can say, rituals and celebrations are usually centered around food. These interesting and very general aspects of the topic, social significance of food, must be kept in mind when considering the nutrition of patients at the end of their lives. Here it is important to weigh up carefully which social interactions, moments of enjoyment and emotions a patient is deprived of by forbidding him to eat orally. In the following, the basic topic of nutrition in Parkinson's patients will be dealt with first, and in particular the problems associated with swallowing disorders will be worked out. Let's talk now about nutrition and hydration in advanced stage of Parkinson's disease. In this section, we will first present some basic ideas about nutrition in an advanced phase of the disease, discuss possible reasons for dysphagia, general requirements for food intake, requirements for food in terms of consistency, as well as tools that can provide support. In Parkinson's disease there exists no specific diet, especially not in advanced stages. The prevalence of being underweight is as high as 22 to 23%. The prevention of weight gain and weight loss are priorities. Excessive weight gain may impact on overall mobility and make moving around even more difficult. Constipation is a non-motor symptom that can occur frequently, up to 80%, in Parkinson's patients, and how many of the non-motor symptoms can exist long before motor symptoms occur. The cause of constipation appears to be delayed bowel movement due to degeneration in the autonomic nervous system of the bowel. In addition, Parkinson-specific medication can aggravate the constipation. A simple remedy to counteract constipation is a sufficient supply of fluid and fiber. In a large number of Parkinson patients, problems with swallowing occur. Possible causes for difficulties eating and drinking are diverse and need to be cleared. For example, they may lay in deterioration of the Parkinson's disease, a sore mouth, pain anywhere in the body or a flu, etc. But also structural alteration in the area of the esophagus or the pharynx as a possible cause must be excluded. Not wanting or not being able to eat or drink any longer might be a sign for the emerging dying phase. If you feel insecure, or need help, please contact the responsible nurse or health care provider, Parkinson's disease nurse or ordinary nurse, or the treating physician. Swallowing disorders can occur in all phases of the disease, but increase with the severity of the disease. The cause of swallowing disorders is manifold and includes problems to transport the food in the oral cavity, problems with chewing, sialorrhea or pseudohypersalivation, which means the patient has increased salivation. This is not caused by increased saliva production, but by reduced swallowing. Reduction of the swallowing reflex. Disturbed swallowing processes with delayed or incomplete glottis closure. And reduced peristalsis of the pharynx and esophagus. Main complications linked to swallowing problems are silent aspiration, which is when food or liquid from the mouth enters the lungs rather than the stomach, without any of the usual signs of coughing or choking. This can lead to a chest infection, known as aspiration pneumonia. Not eating enough to maintain good general health, known as malnutrition. Not drinking enough, which can lead to other medical issues, such as constipation or dehydration. Having problems administering the medication. A rare occurrence is food blocking the airway and stopping your breathing, known as asphyxiation. This is a list of symptoms that can help to identify a swallowing disorder. These symptoms are discomfort in the chest or throat, inability to clear food from the mouth, drooling, food sticking in the throat, problems swallowing medication, choking on food, liquid or salvia, pain when swallowing, a gurgly voice, coughing when eating or drinking. Eating and drinking is far more important than just the intake of nutrients. Among other things, it is associated with well-being, social interaction and the feeling of security. Aspects that are especially important in a palliative phase of a disease. Especially in an advanced phase, however, swallowing disorders increase and the risk of complications caused by swallowing disorders rises. So it remains a fine line to weigh up to what extent patients can continue to enjoy the comfort of food and drink. There are some basic requirements for the intake of food, fluids and medication. A simple test allows the presence of swallowing disorders to be detected even more easily. If swallowing disorders are present, a speech therapist must be consulted with a request for recommendations on food intake. Some very basic tests help to decide whether a patient is still able to eat safely. If anything is unclear, a speech therapist must be consulted. First of all, the feasibility of swallowing has to be checked. Is the patient awake for 15 minutes straight through? Is patient attentive? If he is able to fix his gaze, he remains in the situation. If one of the questions is answered with no, the patient should under no circumstances receive food or liquid without the consultation of a speech therapist. A simple test allows the presence of swallowing disorders to be detected even more easily. The Swallowing Disturbance Questionnaire is an self-assessment existing of 15 questions. Patients with a score more than 12.5 should be referred to a comprehensive swallowing assessment. If swallowing disorders are present, a speech therapist must be consulted with a request for recommendations on food intake. The decision whether a patient is still able to eat and drink normally is difficult in this phase of the disease. It is likely that a safe oral food intake will no longer be possible for a very large proportion of patients. The alternative to an oral food intake is the installation of a permanent feeding tube. This is very often not desired by patients and relatives. As published by Evans et al. In 2019. Oral feeding with acknowledged risk may be a valid strategy. Strategies for feeding patients in this way can take many forms that depend very much on what is right for the individual and with varying risks. Decision-making and management of risk feeding is complex, and assessments must be made of both prognosis and capacity to consent to safest feeding recommendations. Dysphagia management involves behavioral therapy guided by speech and language therapists, including dietary modification, postural adjustments and airway closure maneuvers to protect the airway. You may find the following recommendations on food intake helpful. Avoid hard, dry or crumbly foods. Meat that is tough or chewy can be difficult to swallow. Try eating sitting upright in your chair. Try planning your meals, for when your medication is working. Avoid trying to eat large meals when you are off. Try to eat when you are less tired. This may mean moving your main meal to lunchtime rather than in the evening. Sometimes people with Parkinson's have problems swallowing fluids. And your speech therapist can suggest fluids that thicken well to help maximize your fluid intake. Thickening agents are available in pharmacies. Depending on the amount of the thickening agent, drinks can have a jelly-like consistency. Thickening can prevent aspiration, and thus prevent the risk of pneumonia. There are many types of adapted utensils for eating and drinking available that may be worth considering. An occupational therapist can advise you on the right equipment for your needs. In the following we discuss several aspects the speech therapists of the Elena Clinic at Kassel recommend for a safe food intake. Well-fitting dentures are necessary for good chewing and swallowing. Consult your dentist if necessary. The temperature of the food or liquid can play a role in swallowing blockages. Ice-cold or hot food is sometimes easier to swallow. Tablets are often easier to take with apple sauce or fruit pulp other than with liquid. At hypersalivation it is helpful to suck something acidic or salty or chew gum to stimulate swallowing, which also helps against dry mouth. Concentrating on food or drink helps to avoid swallowing by turning off the TV and radio during the meal, for example, or by not talking while eating. Observe a good sitting and head position while eating. Sit upright, bend your head slightly forward to swallow. Take small sips or bites, eat with a small spoon if necessary. Swallow your mouth empty before you continue to eat or drink. Separate food and drink. Do not flush food with liquid. Drinking through a straw often reduces swallowing as it prevents the head from being bent over. Caution with hot drinks. Danger of burns. Thicken drinks lightly if necessary. Suitable thickening agents are available in pharmacies. Avoid problematic food consistencies, for example crumbly or mixed consistencies like soup with garnish. Switch to softer or pureed food if necessary. After meals a good mouth care is necessary. Do not lie down immediately after a meal. Stay in an upright position for about 15 minutes to avoid swallowing afterwards. Swallowing disorders are difficult to influence with medication. The early stages of the disturbed swallowing act can be influenced in some patients by the administration of L-Dopa or apomorphine. A positive effect on the act of swallowing has also been demonstrated for rotigotine patches. Furthermore, logopedic care of these patients can be offered, with recommendations for food and liquid consistency. Rehabilitation treatment, for example adapting bolus characteristics, postural maneuvers and exercise programs should be advised in Parkinson's disease patients with dysphagia in an individual manner, after a multidimensional assessment of the swallowing function. The important question of whether it makes sense to apply a PEG in progressive dysphagia ultimately remains unresolved. We go on to the use of pumps and feeding tubes. There are different ways to feed people artificially over long periods of time. In the following, reference will be made to feeding tubes, as these are sometimes used in Parkinson's patients with severe swallowing disorders. These probes are inserted with the help of endoscopic procedures named gastroscopy. This involves making a small incision in the abdominal wall, through which a tube is then inserted into the stomach or small intestine. In the picture you can see such a percutaneous probe placed in the stomach. In this case it is a PEG tube. In addition, the patient in the picture also has a suprapubic urinary diversion. A special type of gastrointestinal tube, which is especially discussed for patients with Parkinson's disease, is the duodenojejunal tube, which can be used for both feeding and administering levodopa, carbidopa, intestinal gel. This gel form can be attempted in patients who are difficult to adjust in an advanced stage. By continuous administration into the intestine, the absorption of the gel is better guaranteed. The terms feeding tube are used below to represent one of the three types of tube. Few studies examine patients with neurological diseases. Interestingly, the complication rate of PEG insertion has been reported variously, ranging from 1 to 57%. Local wound infection as well as transient leakage of the stomach resulting in fever and pain are also common. However, long-term complications have not been previously investigated, but might be seen in leakage from the tube or occlusion of the punctuation site. The overall mortality has been described between 0 to 28%. These findings indicate that evaluation of the indication, the procedure and the outcome of PEG placement in patients with neurologic diseases needs further investigation. Let's discuss now about the ethical and social implications of feeding tubes. Feeding tube placement in patients with neurologic disease is somewhere between life-prolonging therapies and palliative care. On the one side, PEG insertion prolongs the life of the patient, but it is still unclear to what extent it implies a better quality of life for the patient. Feeding tube placement might be the wish of the relatives, since mouth feeding might be more time-consuming than application of food and fluid via the PEG. Then again, patients might prefer careful hand feeding to tube feeding due to decreased human contact from being tube-fed. On the other hand, feeding tube placement does not influence disease progression, and thereby the patient's suffering might be increased by reaching a disease stage which otherwise would have been avoided. The burden of late and final stage of the disease may increase the suffering of the patient and consequently of the relatives. Palliative care aims to enhance quality of life for the patient, and the relatives the unit of care, and not to prolong life under all circumstances. Therefore, feeding tube placement is under strict consideration in palliative care. The pros and cons are listed here. In addition to the possibility of ensuring a sufficient supply of food and fluid via the probe, medication can also be administered via the probe. The care of the patient is simplified by the probe. In contrast, the presence of a probe can mean a loss of autonomy for the patient, a loss of care by relatives, and of course a probe always carries the risk of medical complications. Swallowing difficulties might be the only clear point in the otherwise very complicated disease trajectories in neurodegenerative disorders, which could be used as a possible marker for the last phase of a disease. As stated above, palliative care should be included early in the trajectory of the disease and not only at this time point, which also is true for feeding tube discussion. Currently, this discussion often occurs shortly before there is a need for PEG insertion, and it would be important to define the best time point. In patients with dementia, feeding tube placement is already well described, and expert opinion refuses PEG insertion when late stage of the disease has been reached. However, in other diseases like in idiopathic Parkinson's disease or even in atypical Parkinsonian disorders like progressive supranuclear palsy, there exists no reliable data on this issue. As discussed in Lex et al., the patient and caregiver should be given the opportunity to consider whether to implement artificial feeding by tube as soon as possible after being diagnosed with Parkinson's disease. Ideally, these questions should be tackled as early as possible in the disease before the patient's poor physical condition or dementia makes such discussions difficult. How, when and why feeding via tube will end must be discussed as soon as the possibility of using tube feeding is raised. It is important to discuss when tube feeding should end. Some patients may fear that feeding will continue while their disease worsens and that their life will be prolonged against their wishes. The main reason for tube feeding is often that the patient's caregiver can no longer face the suffering their loved one is experiencing due to swallowing difficulties and subsequent weight loss, after having cared for the patient, often around the clock, for a very long time, and involving considerable personal sacrifice. A feeding tube enables the administration of medication, which may lead to a permanent improvement in the patient's condition. There is ample evidence regarding administering levodopa pharmaceuticals via a pump and through artificial tubes to enhance overall mobility in patients with Parkinson's disease who can no longer take their medication orally. According to this literature review of Lex et al., before considering feeding by gastrostomy tube, the following precautionary measures should be considered. The patient and caregiver should be given the opportunity to consider whether to implement artificial feeding by tube as soon as possible after being diagnosed with Parkinson's disease. Ideally, these questions should be tackled as early as possible in the disease before the patient's poor physical condition or dementia makes such discussions difficult. After having discussed this ethically challenging question, the patient and his or her family has to be fully aware about its meaning and impact. Instigation and termination of either tube feeding and or infusion of LSIG via tubes are often difficult and demanding tasks. A tube is always an extra risk for infection, and the possibility of disconnection remains as long as the tube is in place. Therefore, it is vital that the patient's caregivers are aware of the challenge posed by an artificial tube. It has to be handled with care and might further complicate already difficult and demanding care scenarios. Patients often do not participate in important social occasions, such as sharing meals with family and or friends when living with an artificial feeding tube. Therefore, a patient's social isolation can worsen. It should be acknowledged that the mortality rate after feeding tube insertion is fairly high. Before the artificial tube is inserted, the patient should consult a gastrointestinal specialist to assess the details of the implementation and to find the best possible tube for his or her particular circumstances. Carers and patients should be fully trained on how to handle the artificial tube, including during hygiene tasks and before, during and after feeds. After tube insertion, patients should spend at least the first 24 hours on a specialized ward, where staff are familiar with postoperative adverse events that may occur. Before implementing a PEG or PEG-J tube, it might be advisable to consider the implementation of a PEG tube and or levodopa intestinal gel should be tried to preserve as much mobility as possible when a patient cannot take medication or nutrition by mouth. But what about nursing care and prevention? Nursing tasks when being confronted with feeding tubes include: firstly, education and instruction of carers. It is important to get instructions on what medication can be administered via feeding tube. If one uses the wrong medication or the incorrect dosages, important medication tends to not work as well as it should. For these questions, please talk to the treating doctor or your local pharmacist. Secondly, sterile, wound dressing. Thirdly, flushing the tube before and after administering medication. Fourthly, flushing the tube before and after feeding. Fifthly, correct positioning. To avoid aspiration pneumonia is recommended. It is essential to make family carers aware that they should tell the healthcare provider in charge immediately if the patient develops infection symptoms, for example fever, pain, reddening of the feeding tube, etc. Another important issue is nutrition at the end of life. End-of-life nutrition comprises various aspects. Firstly, the natural process of dying with a reduced need for food and fluids and the challenges this process poses to the patient's environment are discussed. It is also important to mention the issue of voluntary food and fluid abstinence that some patients choose as a way to accelerate the dying process. With reference to this form of renunciation, the concepts of life saturation are discussed in a Christian spiritual context, and the meaningfulness of involving spiritual counselors is discussed. Seriously ill and dying people usually have significantly less or even no longer the need to eat and drink. This often leads to the association of excruciating starvation and dehydration. A human being cannot, in painful starve or die of thirst, when he does not feel hunger and thirst at all. The voluntary, sometimes even conscious termination of food intake close to the death is part of the natural dying process and can be an expression of autonomy and dignity of the person concerned, as discussed in the guidelines of the German Society for Palliative Care. Members and relatives feel burdened to deal with the changed eating and drinking habits of the patient. They are under pressure to provide the right food and drink and may put the patient unconsciously under pressure with food offers, in order to maintain or extend the life of the loved one. It is a great burden for the family and relatives that the dying person eats and drinks less and less. They fear that he will starve and die of thirst. They also suffer from the fact that they can no longer show their love and affection by preparing culinary delicacies. Relatives should find an independent, enjoyable approach to the subject of nutrition and fluids, free of portion sizes. Excessive intake of food and drink can even cause stressful symptoms for the patient. Adequate oral care can prevent the development of thirst. Jocks et al. Discussed that severely ill patients with a short life expectancy may have the desire to hasten death. One way to bring about their own death earlier than it would have occurred naturally is to voluntarily stop with eating and drinking. Although the dying process is generally reported to be peaceful, symptoms such as thirst, pain, insomnia, anxiety, and delirium may require medical support. Bernbaker stated that the process itself is ethically evaluated as suicidal action. Dying fasting must be regarded as a form of autonomous shaping of the dying process by one's own hand, with the only difference that the shaping in this case takes the form of an omission instead of an active doing. There are gradations on the term suicide in the various texts, which describe V.S.E.D., for example, as a discrete form of suicide, or as an autonomous shaping of the dying process. Why is an evaluation of this process necessary at all? The reason is a legal one. If dying fasting is called suicide, medical support during this process could be punishable. From an ethical point of view, the punishability of suicidality is counterbalanced by the patient's right to self-determination, which would be just as punishable if he or she were to break with forced feeding, and the theological point of view helps by bringing into play the concept of satiety of life. Let us now look at the ethical consequences. One consequence of this is that whoever advocates the Christian prohibition of suicide can also judge fasting to be forbidden or at least morally problematic. In the following slide, the concept of the fullness of life is taken up in a Christian and spiritual context and shows also in the Christian context another possibility to evaluate fasting before death. But apart from the fact that the traditional arguments for the moral inadmissibility of suicide are extremely weak, the moral outlawing of suicide is particularly implausible in this case. It would amount to legitimizing coercive treatment for a patient who is capable of self-determination, or at least to the obligation to do everything in its power to dissuade a patient with the corresponding intentions from his intention. The patient's right to self-determination would be virtually non-existent. Finally, we will discuss about the importance of involving spiritual counselors. In a text by Traugott Rosa, the state of life saturation is thematized. Traugott Rosa is a Protestant theologian and holds the professorship of practical theology at the University of Munster. His thematic focus lies in the field of spiritual components in palliative care. The term saturation with life is contrasted with the term weariness with life. The ambivalence between sated of life and tired of life is a border area. The desire to die, located at the pole tired of life, requires psychological clarification, because if it has treatable causes, then there is a need for action on the supply side of the institution. Saturation with life takes up the biblical term for a socio-political concept for dealing with very elderly, multimorbid people. Life satiety can be used as a term to make the process of voluntarily abstaining from food and fluids more understandable and legitimate. The very term saturation with life describes a way of satiation that would be virtually counteracted by the intake of food. Spiritual tasks are on the one hand to lead conversations that help to differentiate between life tiredness and life satiety. Liturgical activities such as praying, blessing and celebrating the Lord's Supper can also be an essential component of spirituality in palliative care. During this course, a wide variety of topics related to nutrition were discussed. Nursing and speech therapy recommendations allow us to identify swallowing disorders and to deal with these patients more safely. A weighty topic is the question of the sense and necessity of a stomach tube in the advanced course of the disease. It is a highly individual decision. The process of decision-making should be started as early as possible, in a team together with the patient and relatives. The social aspects of nutrition should allow us not to see eating and drinking as a mere intake of nutrients and not to underestimate the importance of participating in a meal together. It should also explain to us the need of many relatives to offer food to their loved ones, and the desire to feed even in the dying phase, so that we can respond to it. And we approached the subject of fasting for the dying from different angles. These different perspectives should help us to make the right decisions and to understand others in their actions.